This is Katie Bodine, and we'll be discussing the Level 1 and Level 2 objectives of Cauda Equina syndrome. Cauda equina is a syndrome that is due to the compression of the caudal end of the spinal cord. So these are your spinal nerve roots. Both motor and sensory pathways are disrupted in this syndrome. Due to the location of the affected nerve root, these symptoms are isolated to the lower extremities and sphincter function. Common causes include a lumbar spine herniated disc. This is actually the number one most common cause. Okay, remember that, herniated disc, most common cause. Other common causes include congenital neurologic abnormalities, for example, spina bifida. Spinal cord infections can occur, particularly in diabetics with uncontrolled glucose or people using IV drugs. Rarely, spinal cord tumors can occur. Arterial venous malformations can occur in the distal cord and rupture. And of course, trauma can occur, as well as spinal stenosis from osteoporosis. And of course, this can be a surgical complication after spinal surgery. Our symptoms and signs, now that we know the cause, they make sense. This is going to be presentation of distal leg weakness, paresis, and sensory loss in the distribution of the affected nerve roots, which is often in the saddle area. We ask people if they are numb in the area between their legs, have them consider riding a horse. Is anything in that distribution numb? Bowel, bladder dysfunction can occur. You can have urinary retention or frequency. You can also have incontinence, so retention or incontinence of bowel and bladder, erectile dysfunction, total loss of rectal tone. You're going to have abnormal wink reflexes when you do your physical exam. Muscle and deep tendon reflexes, DTRs, are going to be decreased, which is unlike a upper spinal cord injury, which causes the acute presentation to have hyperreflexia. If your patient has let this go for some time, or if it's an acutely herniated disc or acute trauma, they can present with complete paralysis of the bilateral lower extremities. Diagnosis is going to be via MRI. This is your imaging modality of choice. Unfortunately, not everyone can physically tolerate an MRI, or your facility might not have an MRI, or it's broken. In that case, you can order a CT myelogram. Plain CT can be done. It's not ideal. It's not going to show you what you need to see on the as far as nerve inflammation, flare abnormalities, but it can be helpful for trauma because CTs are actually superior to MRI when it comes to detecting bony abnormalities. Your treatment is going to focus on causation. We need to relieve the compression. Surgery is going to be required most of the time. If this is inflammation, or in the acute setting, oftentimes we'll give corticosteroids to try to help decrease the inflammation of Cauda equina, the distal cord. This can be done as an epidural injection. Most of the time we give them a parenteral or oral dose of steroid. Again, if you see sphincter dysfunction, any sphincter dysfunction, this is an emergent surgery issue. They need immediate referral or transfer for referral to the right facility because they will require discectomy and laminectomy in order to reverse these causes. We have some key points to review, references, and that will be the end.